imagine, okay? You can even go with the name brand stuff if you want. Like, that's fine. Like, that is fine if you want it. Get that good coating and all that. And we never talk about aspirin, ever. And the reason is that there's not a drug company that's making real money off aspirin. They just aren't, okay? So every way, it's safer. It's partially reversible, because if you're wrong and they're actually having a hemorrhagic stroke, you could give them platelets. It's beautiful in every way, and we just don't do it. So this table, the NNT, looking at STEMIs, aspirin's about as good as lytics, okay? For stroke, 77 for mortality versus TPA, no, the infinite number needed to treat before you save a life. So here's where I get really mad, is you'd say, well, surely those studies that were comparing TPA to placebo gave aspirin, right? Surely they would have done that, right? It's the only thing that I actually see great data for that has consistently shown that it works. No, they didn't. And the reason is because they're lazy. And here's why. You can't give aspirin at the same time that you give TPA. You're actually supposed to hold off on it. It's commonly forgotten that if you have a stroke patient that you think is a stroke and it's not hemorrhagic, and you don't give TPA, which is most of our stroke folks, you should give them an aspirin while they're in the emergency department. Okay? We forget that all the time. It's very easy to forget. But look at this. They actually, the placebo folks didn't get just current best care. They got no care. It's either you got TPA and no aspirin, or you got nothing and no aspirin. So that thing that I just showed you, where about 1 out of 80 folks get completely better because of aspirin, they totally threw that group out because they didn't get an aspirin. And all they would have had to do is, here's your TPA and a placebo dummy pill that's white, and here's your normal saline push, and here's your actual aspirin. That's all they would have had to do. Would have cost very, very little in the study, would not have added any real complexity, and they didn't do it. So even with these garbage studies that made huge statistical errors or were unblinded and all of this, they weren't even using the current best level of care, which was aspirin. I don't know how an IRB let this get through, because people were being harmed by not getting an aspirin right away when they were being randomized into placebo groups in these studies, and no one talks about it.
Well, wouldn't it have made the trial aspirin versus TPA?
It would, but usually that's the appropriate trial. Yeah, because aspirin we knew worked. But yes, you're correct that technically they were saying nothing versus TPA, when if you had a stroke before TPA, everyone got an aspirin. Everybody got an aspirin. So it's really inappropriate to do nothing.
It'd be like doing a pneumonia study and saying, well, we're going to try this new kilocillin versus nothing. You don't get anything for your pneumonia. We'll see how you do. You can't do it. That's, to me, it's shocking.
So, and nobody talks about this, and that's what kills me, is that, like, how on earth did this happen that we weren't even bringing up the fact that these folks didn't get aspirin, okay? So it's terrible that even with that huge advantage of you weren't even getting the standard of care of aspirin, which I actually do think is a true standard of care looking at the evidence that you should get aspirin after a stroke, then even with that, the studies are still questionable to where I don't think that they actually work. Another thing, and this is another thing that's just really not sexy at all, it turns out that if you get really, really good nursing care, people do better. And it's shocking how robust this data is, where the number needed to treat for mortality of 29 is crazy. And it makes sense. Anybody that spent any real time on like an internal medicine service where the folks that just kind of stay there and people aren't getting up and mobilized and getting aggressive rehab, versus if you've ever been at a place that did that, where they're like, oh man, they're walking every day, they're aggressively getting back to quality of life stuff, those folks get better. Because it turns out if you just rot in a bed, like, you don't get better. And it sounds terrible, but it's really hard. And this takes a lot of money, okay? This is not cheap. This is not knocking the inpatient units. It takes a lot of time and nursing money to get that guy up and get them walking and so forth, okay? But it works. And it's even better than aspirin, which I hate saying that line. We don't have enough time to talk about these things. There were some old studies that were negative, Mr. Clean, which is one study, and then a bunch of things that got stopped early. We're moving on. So TPA, they're already looking at replacing it because the patent's running out soon, okay? So this is true. So tenecteplase will probably be the next TPA, and sadly, with this huge study of 75 patients, they showed that it was better than TPA. Good job. And someone has said, oh, it's a Lazarus-like effect, and it's going to be the new standard of care. And yes, I'm totally receiving money. There's also this amazing study. This is one of my favorite studies ever. They hooked up this sweet ambulance with a CT scanner and then, like, crashed around Europe in it. And it's amazing. Like, I don't know how they pulled this off. I'm kind of proud for building this, like, ridiculous thing. They call it the STEMO. I mean, it's just amazing. It's got a CT scanner, and, like, a neurologist would ride around in it, and they, like, throw you in there, and they'd scan you, and then they'd push lytics. And it's amazing. It was $1.4 million to build it, and it took, like, hundreds of thousands of man-hours to do this. And the only thing that they could prove is, yes, it turns out if you have a CT scanner on wheels, you give lytics faster. Thanks, guys. They had zero data that people actually got better with this, which seems like a colossal bad idea to go lights and sirens after you just push thrombolytics. Because if you crash, that person is done. They are done because they just got pushed lytics. So, and then what's happening to our EMS system? People are driving all over the place because if you had a stroke and you're out in the middle of the woods and like the nearest hospital is 20 minutes away, they'll be like, no, don't drive there. Drive an hour to this big center where they have neurologists that can push lytics, okay? So this is royally messing up our EMS system by making these transports go longer and longer to get to them to these centers. So here's the real problem. This is the thing that makes me the angriest out of everything, okay, is that now we can't study it anymore, okay? So it's not like these folks that are supporters of TPA say, all right, I hear what you're saying, Dan. The math looks good. We should do more trials to figure out what that group is. We should find that STEMI. You know, what is that group of people? Because I actually believe that TPA works for somebody. I don't know who that is. Are these 65-year-old diabetics with a certain type of stroke? Are they a narrow range of people with disability scores? We don't know. But lytics probably works. It may only work in such a small group that it's really, really hard to pull off, like within 45 minutes of you having a stroke or something like that. But brain tissue dies really, really quick. Okay? And so it may be that it's almost impossible to use correctly, but there is that group. So that if you ever have someone in the waiting room that literally has a stroke in front of you, that you know that you should rush and go get lytics. That group exists. We just don't know. But because of neurologists saying that this is the standard of care, they will not allow us to study it anymore. Okay? They took those 2 questionably positive studies out of 12 and said, now it's standard of care. You can't look at this anymore. You can no longer do trials. No one is doing trials of TPA versus not TPA. The only trials that are really happening right now are TPA versus interventional clot stuff, which is not the question I want to ask. I really want to emphasize that neurologists are not bad people. They have a potentially very frustrating field because when the brain gets hurt, it doesn't recover very well. Okay? And so if you have a stroke, they had to suffer for decades of, oh, well, you got nothing better than aspirin. And everyone wants to get in there and do something. Trauma surgeons want to cut. Neurologists want to push lytics. That's part of the human experience, okay? I want to give antibiotics when septic guys come in. Like, you just want to do something. It's really frustrating to say, oh, no, you shouldn't. So we should be taking this money that we're spending on lytics, giving it to nurses. We should be doing more studies to actually find that group, okay? And we need to stop torturing our EMS system, okay? So they're not driving around for hours because you have to bypass these smaller hospitals, okay? So some people ask, like, would I use it if it actually did kill people, okay? Like, you have this theoretical drug where I'm going to give it to you, and if you're either going to get totally better or you're going to die, okay? And if that ratio of death to completely better was good enough, I would 110% be in on this drug, okay? I am not actually bothered at all by the fact that TPA probably increases mortality. If I had a significant stroke or a family member of mine had a significant stroke and they were disabled, I would absolutely throw that Hail Mary pass and say, look, I really, really want to get all the way better, okay? I don't want to get a little bit better and then just be bedridden, okay? I'm okay with that. So the mortality stuff actually doesn't bother me. So if I had a stroke, give me an aspirin right away. I might not even want to wait on the CT scan. If I'm having a hemorrhagic stroke, you can just give me platelets later, it's fine. I don't want any TPA. I want to be transferred to a place with good nursing care that can actually get me up and mobilized, okay? And I would say keep those catheters away from me. I just don't think that there's enough literature that says that this is a good idea. I know that there have been 3 papers recently that have showed that in certain centers they had good success rates with a very small subset of people. But I don't want those things in me at all right now. So now what do you do? So I think that we need better guidelines. I think ACEP needs to revise their clinical policy. There's a bunch of folks like myself that are raising quite a bit of hell over this.
Given the fact they just revised it, it seems somewhat unlikely that they're going to be revising it.
Correct.
They actually made the policy, I mean, on the face of it, it looks more strict than it was before. It's out there. I think this medical legally, if you're not offering it when your own clinical policy says that you should offer it, you're skating on kind of thin ice for most of the first one.
You absolutely are. And we need to have better decision-making with neurology ourselves and the patient to actually discuss them, the risks and benefits of these things. We got to improve our nursing care a lot. And we need to keep studying this to find out what that group is, okay? And I really want to emphasize, and this is a sad trend in my lectures, of saying, I'm going to tell you this stuff that doesn't work, and I'm going to go tell you to do it. And unfortunately, I'm stuck saying that you should probably continue to call neurology and give lytics when advised by the guidelines, okay? One angry academic that reads too much literature is not enough to change a clinical policy. We absolutely need to work with our neurology colleagues. And right now, they come down, they talk about folks. I have never stopped anyone from giving lytics ever. By sheer happenstance, I have never actually given it for stroke. Okay, I don't know how that happened, but it's never been relevant. And that's really unlikely. Yeah. Actually, I do give aspirin to all my stroke folks if they're not getting lytics. I mean, it really is shocking how many people don't get that. But don't be a cowboy about this, okay? We still need to work with our neurology colleagues. We are a stroke-centered hospital, and if you go out there and cause inappropriate trouble for folks trying to give an agent, if it's going to work, it probably works better earlier. There's actually very little data for that. But don't be a jerk about this, okay? You got to work with them. And that's what I flew past, the Mr. Clean, and then a bunch of other fairly small trials with it. Mr. Clean was a pretty well-done trial. The main thing I would say about this is that effectiveness versus efficacy. So I know that they were able to get decent results in the Mr. Clean trial at these large centers that had the world's experts with neurointerventional catheters and intra-arterial TPA and that stuff. I don't know that that's going to work in real hospitals with real people because of the Cleveland trial. So they did the same thing with stroke for regular TPA as well. Whenever they stopped early because of benefit, you better believe that they looked at the numbers and like, they look legit, publish it. And that's what they did. They all published at the same time and stopped early. The studies did look pretty well done, but it's a statistical nightmare to figure out whether your results are actually significant if you call the game early. Because that would be like Georgia calling the game when they were beating Tech last year in the second quarter. And then something happened in the fourth quarter, and I don't want to talk about it right now. But that's kind of what happened. But I think the Mr. Clean trial was a pretty well-done study. It has its problems, but I think it's mostly in the applicability elsewhere. And it completely ignores the fact that study after study before it were all negative. So I think that it's calling the game early to say that, look, we can't even study this anymore. We've proven that it works. When they had several studies before Mr. Clean that were actually larger than Mr. Clean, they were all negative. I think they're calling the game too early. But I think interventional methods are actually probably the future, and some of those probably work for a very narrow subset. But they only accepted about 1% to 2% of all strokes to actually get those catheters. So there's certainly not an overall systems solution to this problem. So the mark of a good scientist is the willingness to change their mind about something. I was one of the biggest therapeutic hypothermia folks in the program. I may have cooled the first person in the MICU here as a resident because I'm sorry, Richard, I literally stole cold saline from downstairs, told the nurse, and then went upstairs and cooled the guy while I was a MICU rotator, okay? Probably shouldn't say that on a microphone. yeah, I'm sorry. But basically I saw the moment and I struck, and the attending was like, I don't know what Dan's doing, but okay, and we cooled him, and I felt great about it. And then a study comes along that's bigger than the old studies and showed that actually we don't need to cool him that cold. We just need to cool him a little bit. And I changed my mind because I believe in data, okay? And what the opposite of that is just firmly believing, like, it's going to work, just keep studying it. And once you get a positive study, being like, oh, it's unethical now. We got that one study that shows that it worked. Stop studying it. We can't talk about this anymore. And they call the game early, okay? They won't let it study anymore because people should change. We should modify it. Maybe the dosing is wrong. Maybe they need a higher or lower dose. We don't know. So I agree with you that it's amazing that people that should know how to do statistics are making such a glaring error. So the myth's debunked. It's not different than the other lytics. It doesn't cause a Lazarus effect that's ever been seen in any evidence-based literature. It's not been consistently shown beneficial in trials. In fact, the opposite could be said. It should not be the standard of care, and it's not the only effective therapy. So we should focus on the other ones that work until someone shows that it does. And there are some really tiny references. Thanks, guys.